Depression is the most prevalent mental disorder of late life. A commonly accepted estimate by self-report is that 25% of the elderly experience a depression. Depression is frequently overlooked, misdiagnosed, and inadequately treated. Overlooked because of the myth that it is a normal reaction to old age. Misdiagnosed because it can be present in a variety of subtle and sometimes confusing ways, such as pain, apathy, or pseudo-dementia. Many elderly do not report feeling depressed. They are part of a generation who have not learned to discuss mood and emotional issues with healthcare professionals. Instead, they are more likely to report physical symptoms. If depression is identified, it frequently is inadequately treated, although it is the most treatable mental health problem in the elderly. When depression is untreated or inadequately treated, the costs are many. For the individual, there's a reduced satisfaction with life and psychological and physical discomfort. Financial costs include more visits to doctors and more lab work to evaluate somatic complaints. As the person becomes more distraught and dependent, there are earlier admissions to nursing homes, where the individual may feel trapped and neglected by loved ones, which serves to increase the depression. The ultimate cost is a high suicide rate among the elderly. The elderly constitute approximately 10% of the population and account for 25% of reported suicides. Depressed men over age 50 are most successful at carrying out suicidal thoughts. Knowing the signs and symptoms of depression is extremely important for caregivers. Observing for and questioning the client about the presence of symptoms of depression provides a focus for the assessment interview. Developing client-focused goals based on the client's symptoms allows for measurable behavioral objectives and a realistic evaluation of client progress. Interventions are most relevant when they specifically address the client's symptoms. The Diagnostic and Statistical Manual of Mental Disorders lists 9 primary symptoms of depression. They are: 1. A depressed mood. The client may report feeling sad, hopeless, discouraged, blue, or down in the dumps. The person may seem grouchy, hostile, in ill humor, or cantankerous. These latter symptoms may be interpreted simplistically or judgmentally and not taken seriously. The elderly person may not directly report feeling depressed because of the perceived stigma of being mentally weak. 2. There is a markedly diminished interest or pleasure in all or almost all activities. The client may appear apathetic or may report not caring about anything anymore.
Hi, Mrs. McCall. How about going for a walk down to the activities room? There's a wonderful group coming in for a sing-along.
No, I don't want to go.
Oh, what's wrong, Mrs. McCall?
Oh, I don't care about anything. My friends and family, they call and want to visit, but I don't even feel like bothering to get dressed to see them. I just don't feel like doing anything.
3. Is there a change in appetite or weight not related to dieting? For the elderly, this will be most typically a decrease in appetite and weight. A physical illness could also lead to the decreased appetite and weight loss and must be ruled out. 4. Does the client report a change in sleep pattern? This could be insomnia or hypersomnia. When assessing the elderly, keep in mind that normally the elderly need less sleep than earlier in their lives. Ask if the change in sleep patterns began around the same time other symptoms appeared. Also, when the person is institutionalized, sleep disruption can result from environmental stimuli and treatment protocols. 5. Is there a change in the pace of psychomotor activity? Agitation may be observed through pacing, hand-wringing, or restlessness. The client may operate in slow motion, for instance, slowed speech, slowed movements, mutism, or taking long pauses before responding. 6. Is fatigue or loss of energy present? The individual may complain that the smallest task seems difficult. It is important to avoid being judgmental or to interpret the client's behavior as being lazy or unmotivated.
How you feeling?
Oh, I'm tired. I'm too tired to brush my hair, brush my teeth. Just leave me be. I'm too tired. I think I'll stay in bed today.
7. The individual may express feelings of worthlessness or excessive or inappropriate guilt. When asked about how he or she feels about oneself, the response may be an exaggerated negative evaluation of themselves.
Mr. Brandt, how are you doing? Mr. Brandt, I understand your son is coming in to take you out for a ride this afternoon.
I don't know why I'm such a bother. My family would be better off without me to worry about. What good am I to myself or anyone else?
8. Observe for a diminished ability to think or concentrate, or indecisiveness. The person may complain of poor memory and being easily distracted.
Oh, this looks like an exciting story, Mrs. McCall. What's it about?
Oh, I don't know. I can't even concentrate. I don't know what I'm watching.
This symptom in particular may lead one to conclude that dementia is present. With depression, the client may communicate more distress about this symptom than the dementia client. It is important to ask about a past history of depression and also look for other symptoms of depression. An assessment of dementia is also called for here. The two disorders may coexist. 9. Are recurrent thoughts of death or suicide or a specific plan for committing suicide expressed? Or has suicide been attempted? In addition, hypochondriacal complaints are a characteristic feature of depression in older age. It is important that a medical evaluation be done to assess for physiological causes. Adverse effects of medication must be considered also. Here again, it is easy to lose one's objectivity and label the older person a bore, a chronic complainer, or a hypochondriac and miss the underlying depression. Once the client has been assessed and found to be depressed, it is time to search for the underlying causes. Frequently in the elderly, we find multiple contributors to the depressed feelings. Some of the most common causes or predisposing factors are genetic predisposition. Mood disorders are more common among biological relatives who have experienced these disorders than among the general population. It is helpful to ask about family history of depression and/or mania. However, the older person's relatives may have gone untreated due to the unavailability of treatment or the stigma of treatment in the past. Also, the depression may have been masked by substance abuse. A second area to assess are the organic contributors. In general, physical illness is one of the most common precipitants of depression in the elderly, not only because of the effect on the central nervous system, but also because of the actual or threatened losses associated with the illness. Endocrine disorders should be ruled out, such as hypo or hyperthyroidism and hypo or hyperadrenocorticism. Also, viral illness such as influenza, cancers which may have depressogenic effects such as cancer of the pancreas, and structural changes in the brain such as stroke, should be ruled out when assessing depression in the elderly. Medications which may contribute to depression are analgesics, anti-anxiety drugs, sedatives or hypnotics, antihypertensive agents, antipsychotic medications, cancer chemotherapeutic agents, and cortisone.
Mrs. Bassinger, what can I do for you, dear?
I need something for my nerves. I feel terrible.
You feel terrible?
Do not overlook the use of alcohol or other mood-altering drugs in the elderly. Many of today's elderly women were in the high-risk group during the 60s for prescription drug abuse, particularly drugs such as Valium, Librium, and sedatives. Sometimes stereotype thinking gets in the way of assessing for alcohol abuse with elderly clients. The National Institute for Alcohol Abuse has estimated that 2/3 of the senior population uses alcohol, and 15% of these people become alcoholics. The third area to assess are the stressors the individual has experienced. The elderly are at risk for experiencing more stressors of greater severity over a shorter period of time than any other age group. The losses associated with these stressors may be actual or threatened. Common losses experienced by the elderly are loss of relationships with others, financial losses, loss of possessions, loss of one's own health, or the deterioration of the health of significant others. With frequent losses, the individual does not complete the grief process following one loss before being confronted by another loss. The individual may have multiple setbacks and therefore feels stuck in the grief process. The person has difficulty in reaching acceptance and is afraid to feel hopeful about the future, fearing another disappointment. Expecting and preparing oneself for another loss becomes a way to cope, but may also be part of negative thinking, which fuels the depression.